Hello and welcome to my channel. Today we are going to talk about a very common complaint, not just in the movement disorders clinic, but also in the general neurology clinic and also in the primary care clinic. We are talking about tremors, shakiness. Many times patients ask why I shake so much. Should I concern about this? What should I do? Well, we are going to answer all these questions in the most practical way possible. Let me start saying this. Everybody has a physiologic tremor. It's physiologic. Physiologic means normal. The problem is sometimes it gets exacerbated, too much tremors. For example, when you are stressed out, when you are having anxiety, severe anxiety episodes, when you drink a lot of caffeine, when you haven't slept well, if you have all these issues or one of them, you will shake a lot, and that's normal, that's physiologic. Typically, the physiologic tremor is not visible, but when it's excessive, you are able to detect the tremors, especially when you put your hands in front of you or in this position, you will be able to see the tremor. It gets worse when you cannot relax. For example, when you are in a severe anxiety episode, your adrenaline in your bloodstream will be high, increase. Maybe because your mind is preparing you for a flight and flight response to save your life, or because you have a maladaptive level of anxiety. In fact, shakiness or tremor is the most common involuntary movement disorder, but only a fraction of those patients seek medical attention. Tremors are clinically detectable in approximately 95% of the time. When you put patients to do this, or people to do this or this, at least or approximately 95% of the people, you can actually see the tremors. We call that a postural tremor. This type of tremors is also caused by medication, side effect of medication, and usually dose-dependent side effect. Also, you can have metabolic process going on. For example, your glucose, your sugar decrease, and then you might be shaky. Also, you might have abnormal thyroid function, and then you will be shaky as well. So in other words, there are many reasons for you to have excessive physiologic tremors. Let me summarize this. When you have an action tremor, and the action tremor is mostly postural, like this, without any specific position, then the most likely reason for you to have these tremors is physiologic, which means something is going on around you. For example, medications, anxiety, metabolic process, exacerbating, increasing, making you to have excessive physiologic tremor. Then what to do? Well, try to find the cause, the underlying cause, if possible. If you think that you are taking medications or a medication that might be exacerbating the tremors, maybe the only thing that you have to do is just decreasing the doses. Sometimes you need a medication when that doesn't work. For example, I sometimes use in those cases my small dose of propranolol, 10 milligrams twice daily. That might be enough, that might help. Now, let's talk now about the most common pathological tremor. I am talking about essential tremor. This is not physiologic, this is a pathology. Essential tremor is different. Essential tremor is predominantly kinetic tremor. This is the kinetic tremor. This is the postural tremor. Postural tremor, this is the kinetic tremor. So essential tremor, the predominant type of tremor is the kinetic tremor, which is one of the action tremor. Remember, action tremor are divided mostly in postural and kinetic. So essential tremor affect the neck and the voice. However, enhanced physiologic tremor can also affect the voice, but should not affect the head. I actually have a video to help patients and providers to differentiate between enhanced physiologic tremor and essential tremor. You can watch that video. It's very short, and you will learn a lot. Now, what to do when you make the diagnosis of essential tremor? Well, sometimes you don't need to do absolutely nothing. The first question that you need to ask yourself, are these tremors affecting your function, affecting your life? If these tremors are affecting your life, then you need to do something about it. You need to treat that. The problem is that 30 to 50% of the patient, they don't respond to medication. That's a lot of people. Well, let's start with this. Assuming that your tremors are affecting your life, right? So my first choice, based on data and my preference and my patient preference, is propranolol. Propranolol is a anti-blood pressure medication approved by FDA for that, also approved by FDA for migraine headaches, and also for essential tremor. Propranolol, people actually tolerate propranolol pretty well. The only relative contraindication is if you have severe asthma. For example, in a patient who is using albuterol, which is a medication that we use for asthma, it doesn't make sense too much to use a beta blocker like propranolol, because you are causing the opposite effect, right? It doesn't make sense to use that. So those patients, probably it is not a good idea to use a propranolol. Other example is if you have a bradycardia, which is a low pulse, less than 60, that's not a good idea, because this medication will actually decrease the heart rate. Other reason why I will not use propranolol is in a very active patient and a runner. Okay, obviously runners can have essential tremor as well. So propranolol will not be a good choice. They will feel very dizzy when they are running, because you are blocking the heart rate. So otherwise, propranolol is a pretty safe choice. I always start very, very low. So I'm talking about 10 milligrams twice or 3 times a day, and I will go up progressively. Sometimes I reach 120 milligrams total dose. And if that doesn't work, or the patient cannot tolerate, I typically add my second choice. And I'm talking about primidone. So primidone is an anti-seizure medication, very old medication, very cheap medication, effective for tremors, is the first line of treatment. But why is my second choice? Because of the side effects. A lot of patients cannot tolerate the medication. For example, many of them during the first dose, they feel very sick. They feel nauseated, and they are not going to try this medication again. Now, sometimes when they are able to tolerate the medication, there is a dose-dependent side effect. And the most common one is sedation. That's the most common one with primidone, because primidone is metabolized in other medications, such as phenobarbital. Approximately 25% of the primidone is metabolized to phenobarbital, and phenobarbital is a very sedated medication. Also, primidone and phenobarbital might cause cognitive issues, memory issues. It might actually cause depression also as well, balance issues. Some patients, they have significant balance issues as well and leading to falls. Some patients, they have vertigo, dizziness. And sometimes what you need to do when you have those side effects is just decreasing the doses. That might be enough, but some patients, you actually need to stop the medication progressively. You never stop those medications cold turkey, okay? This is very important. That apply to the majority of the medication in neurology, the majority of them, but especially propranolol and primidone, because you will have for example, with propranolol, you will have a rebound effect. And the primidone, actually, you might have even a seizure if you stop cold turkey. Now, doses. So the doses should be very small from the beginning. You start a low dose. The tablets that we have available are 50 milligrams and 250 milligrams. So 50 milligrams and 250 milligrams. So I start with half of the 50 milligrams. So I'm talking about 12.5 milligrams daily at night. Sometimes it's difficult to cut the tablet, so I try sometimes at 25 milligrams, which is half of the 50 milligrams, and increase every 5 to usually a week. Every week you increase a little bit, and I reach doses of 250 milligrams total dose and daily, divided in 3 times. If that doesn't work, and actually I try to combine both of them. We have data when you combine the primidone and propranolol, patients do a little bit better. And sometimes I just try to use a low dose of propranolol and low dose of primidone. And that might work for many patients. Now, if that doesn't work, then you go to the next type of medications. The second choice, we call that the second choice. I'm talking about gabapentin and topiramate, Topamax. Let's start with topiramate. Topiramate is a relatively safe medication. It's an anti-seizure medication. The problem is that based on trials, you require higher doses to see some benefit from the tremor standpoint. So in my experience, I need to reach at least 100 milligrams twice daily in order to see some benefits. Definitely, there are some patients that might improve with only 50 milligrams twice daily, but the majority of them, they need to go high. And when you go high with this medication, you might have some issues. Number one, sedation. Now, all of those medications might cause sedation. You might have what we call word finding difficulty. You might have kidney stones. So kidney stone might occur in approximately 1.6% of the patient. So in a patient with a history of kidney stones, I might think twice. I have done that before and they are doing fine. But if they really had a recent episode of kidney stone, I would not put patient on topiramate. The other side effect, which could be a good side effect for many patients, is weight loss. Some patients like that and would be a good idea. So it's an option, but would be the second choice after trying primidone or propranolol, or because patient cannot take or tolerate those two medications before. Then the other choice is gabapentin. Gabapentin is another anti-seizure medication. We try gabapentin approximately, I start with 100 milligrams 3 times a day, and then increase progressively, usually over 300 3 times a day, to see some benefits, if any, with gabapentin. The good thing about gabapentin is people tolerate gabapentin pretty well. The main side effect is, again, sedation, and it's a dose-dependent side effect. There is no interaction with any medication. So you can combine with all your medication without any problems. Now let's talk about the last option in terms of medication. We call this the third line treatment. I'm talking about benzodiazepines. Benzodiazepines are, for example, clonazepam or alprazolam. We call alprazolam Xanax. So those medications might help tremors, especially in the setting of anxiety, physiologic type of tremor, enhanced physiologic tremor. However, I will tell you, 90%, 99% of the time, you are not going to see me using those medications. Why? Because they are highly associated with addiction. They are not too effective. They might lead to falls because affect your balance, affect your cognition. Certainly it's an option, but again, when you have a severe anxiety causing you to have increased excessive physiologic tremor, and only for a short period of time. Otherwise, I typically don't use benzodiazepines to treat my patients with tremors. Now, let's talk about other type of treatments. These are not medications. Well, this is not, they are not oral medications. Some of them are procedures. Okay. Now, one of them I want to talk is something that we call Calatril. We call this a neuromodulation, which is actually a wrist device, looks like a watch, causing stimulation in two nerves that we have here, the ulnar nerve and the radial nerve. So when you stimulate those nerves, somehow decrease the amplitude of the tremors. Approximately, they say approximately 60%, even some patients 80%. I have not seen that. This is based on the data. This was approved in 2018, but the problem is the insurance doesn't cover. Insurance are not covering this, to my knowledge, except I think VA covered this. But it's good to try. Actually, improve the tremor for approximately 94 minutes. And no side effect, basically, no major side effect. The only contraindication that you can have with this is if you have a pacemaker or you have a deep brain stimulation, you cannot use that. And if you have a seizure, probably is not good idea to cause a stimulation in certain areas of the brain. Now, there are also some devices that we use, we call that tremor cancellation devices, such as a spoon or a fork with vibration. It might help to reduce the tremor in some patients. They tend to be expensive. And the good thing is that if that doesn't work for you, many of the companies can allow you to return the device and they give you the money back. So you just go to the website. There are multiple websites about this type of devices. The other option is botulinum toxin injection. So when I say botulinum toxin, I'm talking about Botox or Xeomin, and there are two more that I don't use too much. I use mostly Xeomin and Botox. So sometimes I try for hand tremor and a neck tremor too, but hand tremor, because we are talking here about mostly hand tremor. So I inject mostly two muscle. At least the first shot would be two muscle, and they are flexors. One muscle right here and one muscle here. Okay, two muscles, and sometimes another one here, but mostly two muscles. Very low dose. The main problem here is that if I inject too much, I might cause weakness in the hip flexors, mostly because I'm injecting that. However, sometimes the toxin or the Botox or the Xeomin goes to the next muscle, and then it might cause weakness in the grip. Okay, so that might be a side effect. Those side effects or benefit goes away. But I have seen patients with some improvement, probably from 30 to 50%. And there are plenty of data about that. So it's an option, and it's a relatively very, very safe option to try. Now, last option and is surgery. So this is more invasive. I'm going to talk about only two types of surgery. The first one is not technically a surgery because nobody is making holes in your head. We call that an MRI guided ultrasound, which was approved by the FDA in 2016. Like I say, nobody will make holes in your head like in deep brain stimulation, which I'm going to talk about that soon. But still, it's a procedure. They actually destroy some brain tissue with high energy ultrasound in a specific area, small area in the brain, deep in the brain, that is related with the tremors. Very effective, approximately 35 to 75% reduction in the amplitude of the tremor, unilateral, because that's the main thing. Is unilateral, is only one side. Still, we cannot do it both sides, only one side. The main side effect that you might have based on trials is tingling sensation and balance issues. We call that ataxia. So that's the two main problems that you might have. That could be even permanent. Now, my favorite option is deep brain stimulation. Let me tell you this. If I develop essential tremor in the future, and my essential tremor is worse in my right hand, and I'm very right-handed, this hand is useless for me, I'm very right-handed, I will get the surgery. This is me, okay? This is me. I have seen significant benefits in my patient with essential tremor when you use this type of device, this type of surgery. Very effective. Obviously, there is a risk like any type of surgery. If you get a knee surgery, if you get a wrist surgery, there is a risk as well. Scary, yes, because somebody is dealing with your brain. But so far, I haven't seen any big issue. People do well, and we have plenty of data behind this. There are three types of devices that we use. I don't have any preference. I use all of them. I will stop talking here, and I want you to watch this video, and you tell me. So you start having tremors when you turn forward. Okay, now I will turn the DVS off. So the DVS will be turned off now, and you will see. This is a patient with severe essential tremor. So you can see the severity of this tremor. So the DVS will be turned on, and you see the difference. Right? Lots better. So this is one of these very nice cases that you can see the benefits of deep brain stimulation. If you like this video, don't forget to subscribe, and thank you very much. See you soon.